Good afternoon, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association and JBS International, welcome to today's webinar entitled Florida's Recovery Residence Options for Parents with Opioid Use Disorder. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health, JBS International, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Monday, February 4th. 1 to 2 continuing credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number or numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce you to LaRue. Emma is the director of the Aetna Recovery Project. with the Florida Alcohol and Drug Abuse Association. She is also the executive director of the LaRue House, a women's recovery residence located in Daytona Beach, Florida. Prior to accepting this position, Ms. LaRue was with the University of Central Florida as an academic advisor and career coach. Currently, she is a certified career development facilitator through the National Career Development Association. And now I'd like to welcome our presenter, Ginny LaRue. I will turn the presentation over to you.
Thank you, Diane, and welcome everyone to this webinar.
That's not.
Diane?
Yep.
Okay.
Sorry about that. It's loading right now.
Okay. I show that it looks ready. Are we ready? Okay. Well, we'll go again, and I would like to welcome everyone today for Florida's Recovery Residence Options for Parents with Opioid Use Disorder, OUD, as we're going to refer to it throughout the rest of the presentation. Now, Diane, I'm not showing to be able to move this forward.
Okay. I will take over presentation. See if you are able to move the PowerPoint up and down.
No, ma'am. No, ma'am.
Okay. All right. I can. Would you like for me to move it as need be?
If you don't mind, because I'm helpless at this point.
Okay.
All I can do is talk.
Okay.
So go ahead. You may go ahead and move the screen to the next slide, please. And I think you already talked about this, who this presentation is brought to you by. So go ahead and move the screen. So we have 4 learning objectives in this presentation. The first one is to build an understanding of the many challenges that face parents in recovery. Objective 2 is to discuss key reasons why recovery support resources are essential to supporting and sustaining parents in recovery. The third objective will be to consider the stigma present in some facets of the recovery community, impacting parents with OUD receiving MAT, medication-assisted treatment. And number 4 is we will describe the benefits of and need for recovery residences for parents with OUD. Go ahead, Diane. So I was introduced by Diane earlier, and let me just elaborate on that a little bit. I am Ginny LaRue, and I am a person in long-term recovery since April 2003. And what recovery means to me is that today I no longer have to live in a van with my 3 children. I am employable. I am a good partner to my husband. I am a good mother to my 3 adult children. I am even a good pet owner. There was a time that wasn't necessarily the truth. Recovery has brought an education into my life. I have my master's degree in nonprofit management. It has given me the ability to help others through the process and their journey, self-directed journey of recovery. I am the director of a women's recovery residence in Daytona Beach, Florida, called the LaRue House. And I get the privilege of working for the Florida Alcohol and Drug Abuse Association as the director of the Aetna Foundation Recovery Project, which is to create recovery communities throughout the state of Florida. So that's a little bit about me and my journey in recovery. Go ahead, Diane. So we're going to define some things. A lot of times I think I know what the definition is because I think myself to be pretty smart. But then when I start to look at the definition as defined by various organizations or even Webster's, my ideas change. Go ahead, Diane. So let's talk about what recovery is defined as. And this is part of a definition published by the Substance Abuse and Mental Health Services Administration, SAMHSA, and they define recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. I love this definition because this definition doesn't say you have to go to 12-step, or you're only in recovery if you do yoga 3 times a week, or you're only in recovery if you go to detox, or you're not in recovery if you're on an MAT. It doesn't say anything about defining what recovery looks like. It says, we just want you to be healthy and have wellness in your life. It says, we want your recovery to be self-directed. That means that even if I'm working with clinicians, whether it's through the detox process, inpatient treatment, outpatient treatment, follow up with a physician of whatever kind that is through the MAT program, I get to direct my recovery. And then obviously the end part is we all just want to get to our full potential. And that can take a minute for some people. Go ahead, Diane. So a recovery residence is defined as it's a broad term. It usually describes as a sober, safe, healthy living environment. It promotes recovery from alcohol or other substances and associated problems that go with their use. At a minimum, recovery residents offer peer-to-peer recovery support. Some provide professionally delivered clinical services, but ultimately all are aimed at promoting abstinence-based long-term recovery. And we're going to talk about that a little bit later in this presentation, that the word abstinence-based is starting to come out of the definition of a recovery residence because it stigmatizes. Go ahead, Diane. OUD, Centers for Disease Control and Prevention, describe OUD as a problematic pattern of opioid use that causes significant impairment and distress. A diagnosis is based on specific criteria such as unsuccessful efforts to cut down or control use, or use resulting in social problems, failure to fulfill obligations at work, school, or home, among other criteria. And I'll share a little bit about myself. I'm pretty transparent in my life. I was introduced to recovery in 1986, actually earlier than that when I was much younger. And, at the time I would say that I had a substance use disorder. But after 14 years of being a person in recovery, I injured myself and what I self-diagnosed as an opioid use disorder. I abused opioids for several years to the point of losing jobs, not being able to go to school or keep my children in school, and the loss of my home. I was not involved in any social activities, and I could not fulfill many obligations that I had, plus a lot of other things. Go ahead, Diane. So, medication-assisted treatment. SAMHSA describes MAT as the use of medications with counseling and behavioral therapies to treat substance use disorders, SUDs, and prevent opioid overdose. I'm sure many of you on here are familiar with the types of medications that are used. Buprenorphine, naltrexone, and methadone are three, and they're used depending upon the self-directed needs of the patient. Go ahead, Diane. So we're going to talk a little bit about Objective 1 today, which is to build an understanding of the many challenges facing parents in recovery. Next. So let's talk about some statistics for just a minute. As you can see, now this survey went only through 2017, but you can see that from 1999 right on through 2017, more than 72,000 Americans died from overdoses. That averages out to 6,000 people a month, 197 people per day. That means in this day, right now, 197 people will have died due to a drug overdose of some type or drug-related death. That's not a number that I'm very happy with. Go ahead. So parents with untreated OUD or other SUD have influence on the health of the family and the developmental path of their child or children. Children raised by parents with OUD have problems that reveal themselves in harmful ways. I have a couple of listed now: remarkable resilience under worst-case circumstances, developmental problems, pre- and postnatal exposure that creates inadequate bonding, nurturing, disruption of family rituals, family conflicts, inadequate monitoring or supervision and abandonment. And I'm going to share a little bit about myself here. My children, we lived in a van toward the latter part of my youth, and we were homeless, and we were living in shelters, or we were living in parking lots with the van, and I know that my choices affected at that time, of course now they're adult children, but at the time they were, I guess my daughter was 2 or 3, and they're 3 years apart, so you can do the math thereof. And, I think that my children have learned how to get through some problems that they shouldn't have had to deal with because of my youth. My son always tells the story. My oldest son is in recovery now. I just want to share that with you. And my middle son is in treatment as we speak. And my oldest son, when he talks about his story, he always talks about the fact that we lived in a hotel in another state for a little while, and the school bus would come pick him up, and he was always made fun of. And at that time, he tried to commit suicide. And I know that was a direct result of my substance use. Also, my oldest son, because he went to 8 schools in 1 year, had some developmental problems. Of course, when I got into recovery, I addressed some of those, but he was in special education classes. We had to go in and do reports on him, and I had to get him extra help and tutoring. And I believe that he fell behind due to the lack of consistency in his education. And I did not use with any of my children. That is not my story, but it is stories of a lot of people. And, of course, those go with some side effects as well. Go ahead, Diane. Now, remember, you can ask any questions along the way. Somebody is saying they're not seeing their slides. So I don't know, Diane, maybe you can help that person. So we're going to talk about challenges for recovering parents. So relapse prevention. One of the hardest things as I engaged in a program of recovery through my recovery journey, and I didn't have my children right away, and there were some things that I had to do to make sure that relapse was, again, not part of my journey. I had to make sure that I was attending, for me, I attended 12-step meetings, and I had to make sure that I could get there. And a lot of times I had to ask for rides, and I had to do the extra work to get there. So a relapse prevention program, idea or concept is real important to whoever is working with someone in early recovery. I still have a relapse prevention program. When I go to the doctor, my doctor knows I am very transparent about the fact that I don't get opioid drugs, period. Unless I have a bone sticking out, it's not happening. Also, challenges are discipline. Not having role models for discipline, intergenerational parenting skills. I came from a family that was relatively mainstream. My father, he's retired now, was an Episcopal priest. My mother was a homemaker for a period of time and then went to work. Later on, when we were older, we were at church on Sundays. I went to youth camp. I did all of those things. So I had good modeling, but I didn't necessarily bring that with me to the table after I started using. And so learning how to discipline. Now, my father was what some may refer to as on the side of being abusive. He spanked us. We had a lot of yelling in our house, and he was a bully. So I had to learn how to change that behavior and how to find people in my life in recovery that were helping me not spank my children, not bully my children, not yell at my children, find other avenues. And I had to seek outside help, clinical help, in order to help my family become whole again. Overcoming stigma and judgment is another challenge for recovering parents. I've heard many ladies share stories about having a substance-dependent child born and how bad they felt and how they were treated in the hospital by professionals. And there's a stigma and a judgment that goes with that, and that's a challenge that has to be overcome. Changing family roles and dynamics. I want to share about that because when I got into recovery, I found that I didn't have my children, any of them, for the first 9 months that I was in recovery because I had no place for them. I was sleeping on someone's couch. And I all of a sudden, my parents were the parents of my children. And then when I got them back, I had to kind of switch the power dynamics in our house. And it took a while for me to get my footing and for my children to understand that Mommy wasn't going anywhere, that I was really going to be in recovery, and that our lives would have some semblance of normalcy to it. And then balancing parenting and recovery needs and MAT requirements. MAT requirements require clinical appointments with a physician. They require counseling several times a week. And then parenting is you have to learn a whole new way to parent, and that comes with a lot of challenges. And finding balance with all that can be difficult. Also, overindulgence. I'm pretty transparent, and one of the things that I found myself doing for a couple of years in early recovery is parenting out of guilt. saying yes when I really wanted to say no, allowing behaviors to go on because, well, they really went through a hard time. I need to allow that and not make such a big deal out of it. And that overindulgence took a while until people in my recovery support group started saying to me, hey, you don't have to parent out of guilt. There are other ways to accomplish parenting. And that took a while as well. Go ahead, Diane. Developing realistic expectations about recovery and being a parent. Being a parent is difficult on any day, especially when you get into teenagers. They come with their own challenges, even if it's a perfect situation. And then having had a child taken through active use can be difficult. And so sometimes it's a matter of my saying, you know what, I got to be realistic about what's really going to happen here. Am I able to go to a meeting every single night? Or if I am able to go to a meeting every single night, do I have to take my children? And if I do, it's okay that they sit in the corner. My children were not well behaved. And it took a while for them to parrot good behavior. And so I had to be realistic and kind of give myself a break about how recovery was going to look like right along with being a parent. And then parenting education. I told you that my children and I received outside help, clinical help, for a couple of years in order to teach us all how to reunite with one another. And I had to learn some new things. I told you that my bullying and my yelling and spanking had to change, and it did, because somebody helped me do that and saw, you know what, we're going to help you change your behaviors. And trust, my children were always worried about, is she going to go away? Is she going to come back? My daughter especially, because she was much younger, was very needy for a long time because she wasn't sure that I was coming back. And then understanding medication-assisted treatment and child case requirements. There's I know that when someone's on medication-assisted treatment, there's a requirement you have to meet with the clinicians often. You have to go to counseling, and then you have to meet your case requirements, whatever those are, and then you have to go to court. You have to meet with that case manager, and it can be a lot. And so I have a friend of mine who talked to me about how he accommodates. Like he'll say, instead of going to an MAT counseling meeting, go to a 12-step meeting, and we'll count that. So that there's some give and take a little bit, so that we don't overwhelm the parent in new recovery. Managing transitions, that's real important, because what happens in detox and in residential or outpatient to a recovery residence to stable housing, each of those transitions comes with challenges, not only challenges for the person in recovery, but also challenges for the family as well, for the children. So understanding that when I leave the recovery house, I talk to the ladies who live in my recovery house about, hey, don't get too good too fast. Don't be in a hurry to get out the door. Make sure that you've got yourself a little bit of a nest egg so that you can get first, last, and security somewhere. Do you need a roommate? How are you going to transition? Who's going to help you with driving kids to school? And we kind of create a plan to transition back into the usual customary housing. Go ahead, Diane. So we're going to talk a little bit later about stigma, but there is a high stigma for MAT from recovery residences staff based on complete abstinence. We talked about that earlier, how a lot of recovery residences, for whatever the various reasons are, and we are going to discuss that in a little while, have their own stigma about medication-assisted treatment. And that takes education. It takes education from people like me who have changed my views about medication-assisted treatment in a recovery residence. It took a shift for me I was at a opioid summit last year, beginning of last year, and I was listening to a panel of Recovery Community Organization executive directors. And one of the executive directors talked about, who am I to say that someone's not in recovery if they are on some type of medication-assisted treatment program, but they are living in a recovery house, they are going to work every day, they are paying their child support, they are meeting their case plan, they are paying their bills, they're spending time with their child. Why do I think that that's not in recovery? Because remember, we would go back to the initial definition of recovery, self-directed. I got into recovery based on abstinent base. So when I started hearing about medication-assisted treatment, I got scared because for some reason I thought that meant that how I got into recovery wasn't right. And the truth is, it was right for me. It doesn't necessarily make it right for the person sitting to my right or the person sitting to my left. It means that is my path. It was self-directed. I made the choice to do it that way. And that was the shift for me as a recovery residence owner. So recovery residence owners and staff have bias based on personal experience, and I just talked about that. In the LaRue house, for example, if someone comes in on a medication-assisted treatment program, there's some accountability. So we can cut down on any abuse. They have to have their medications locked. There are only 2 people in the house who know that they're on an MAT, and that is myself as the owner and the house manager. No different than if they were diabetic and needed to take insulin. I don't tell anybody that's them to tell their own story. That's not mine to tell. And we value that privacy. Also, we make sure that we have communication with any clinicians, and they give us permission to do that should there be a question about abuse of a medication-assisted treatment. And then the idea of separating MAT clients in recovery residences, that also stigmatizes. I don't separate. Everybody lives on the same floor in the same building, and one does not know who the other is. And nor if someone had mental health issues and they were taking medication for that, I don't tell anybody about that. They get to tell. I don't get to tell. And so we don't separate people in a recovery residence because it stigmatizes. It, again, evokes shame and separatism that's not necessary. Education of recovery residences about co-occurring in medications. A lot of treatment centers discovered that there's a co-occurring disorder while they're in treatment, and they're prescribed medications. And recovery residences, again, get scared because a lot of recovery residence owners are abstinent-based through their own personal experience. And the more we educate owners, the more we're going to be open to allowing persons of varying types on various medications, no matter what we identify them as, into recovery residences. And then recovery residences addressing stressors with clients, legal issues, child issues, DCF or CPC cases. We have a lot of women who come through the recovery house that have lost their children for one reason or another. And we actually had a case here not too long ago at my house where we had a woman who was really in the system and ended up losing her daughters, and she ended up having a setback, and she ended up using again, and she has still not come back from that. And so there are a lot of stresses, and we, as a recovery house, I made sure that we prepared her for that, and we tried to talk about what would happen. And it can be a very delicate balance act with making sure that they talk about how they're feeling in the house, and that we keep that peer support around them to help blanket them. And then there are some others, and if you have some other challenges for recovery parents, type them in. We can talk about them. Oh, go ahead, Diane. So factors that contribute to relapse with parents. One is overwhelmed with responsibility. Everything is hard. When we first get into the recovery journey, just getting a job, learning how to make your bed, doing your chores, being accountable, being home at curfew, and then getting the job and keeping it, getting to the bus, or finding transportation of some kind, whether you have a car or need to ride the bus. All of those things can be overwhelming, and then you throw on top of that the next item, which is financial pressures, old bills, bad credit, no job or no job skills. I'm always so grateful to my father, who prodded me to take typing in high school, and of course I was resistant. And I am so grateful today that he did that, because I came with a skill. I could type 90 words a minute, and that meant that I could get a job pretty quickly. But not everybody has that story. And so some people don't even have high school diplomas. Some people need to be encouraged to go, hey, let's look at going to get some support with getting your GED, or how about we go walk along the community or state college in your area and take a look at maybe what some of the options are that you might be interested in, and then helping to deal with some of the the old bills and or bad credit. In my case, I had both. I had a lot of hospital bills. I had bad credit. I had to do some work at getting some things turned around, because credit really affects where you can live and how you can live. Housing, a lot. I'm transparent, so I'm going to tell you that I have a 33-year-old criminal background. In 1986, I broke the law. And I stayed on probation and made restitution and did everything I was supposed to do the right thing and restore and repair what I had broken. However, I still have a criminal background, and that affects getting a job. That affects housing. Now, not so much anymore, because there's time and distance that has taken place. But initially, that was a problem. I could not find housing for my children and I. I had to live in housing. I remember the first place I got when I got into recovery and I got all my children back, it was a 600-square-foot apartment, 2 bedrooms, and my daughter and I shared a room, and my 2 boys shared a room. And that was all I could afford, and that was all I could get into, because of not only financial, but also my criminal background. A lot of times, parents in recovery don't have healthy support systems. They're still holding on to relationships that are unhealthy with old friends. Or maybe a family member is not healthy for them. Either they're abusive or they're still active in use. And so finding new support systems becomes a challenge for people, and it can contribute to a relapse, because these are stressors that add to relapse. So low self-worth, lack of confidence to start a new life. For me, I had a high school diploma, but I didn't, and I could type, but I didn't have an education. And I had always wanted an education. So somebody told me to go down to the local community college at the time and get into, I think it was called Fresh Start. And I did. I enrolled, and they gave me the confidence to go, okay, in the fall, I'm going to sign up for a couple of classes. I remember sitting in my math class, and it was baby math. And they were talking about negative and positive numbers, and I burst into tears because I didn't think I could do that. And it wasn't until I went and asked for help. I got a tutor. I got into some programs that offered additional assistance. I started to see that I could do that. And I took my life semester by semester, and every time I did well in a semester, that built my self-esteem. Sometimes it's nothing more than just getting through the next court date that builds our self-esteem. Sometimes it's, paying a bill on time that builds our self-esteem. Those little nuggets are what help us build our self-esteem and self-worth so we can continue on this new life. There's a saying that if you haven't done it in a recovery mode, you really haven't done it. So it's a new skill. We're learning new skills without being intoxicated. Boredom. It took me a while to, at the first, recovery is really exciting and fun, and everybody goes out to eat after 12-step meetings, or, there's all this support and love, and then all of a sudden it's like, okay, now what do I do? What do I do now? Well, I could call my old buddy, or I could call my friend over here, and I could hang out with them, or I could learn and get a hobby. It took me many years in recovery to get hobbies. I learned I love to run. I learned I love to garden. I'm a reader. I love to read. I love information. I started reading a lot of books. So that takes time to develop what's right for me and for the person in recovery. Triggers. For a long time, because I was an opioid user, I could not go into some grocery stores without walking smack dab into the pharmacy. And that was a trigger for me. And so what I had to do was continue to go in grocery shop, but instead of looking at the pharmacy, I turned my head to the left for a long time so that wasn't a trigger for me. And once I got past it, it was better. Sometimes also, like going to see family can be a trigger. Driving down a certain road can be a trigger. A song can be a trigger. So learning what the triggers are is important in not contributing to a relapse. And then early recovery comes with a lot of ups and downs. If you could see me visually, we talk about high spikes if you were looking at a graph. And over time in recovery, those spikes turn into curves, and then the curves turn into more flat. And the ups and downs aren't as high, but initially, oh my gosh, I was all over the place. And people that I have seen in the recovery house are all over the place. They're up, they're down, and a lot of it has to do with what type of drug they use too. You can always tell who use stimulants because they're really hard to settle down. So those kinds of things help with not contributing to relapse for parents. Go ahead, Diane. Do we have any questions? It's a quiet group. All right, we'll continue. So objective 2, we're going to discuss key reasons why recovery support resources are essential to supporting and sustaining parents in recovery. Go ahead, Diane. So recovery support services, RSS, as it's in the business called, addiction treatment with transition into RSS has been shown to be effective, with many people achieving long-term recovery. Research on peer recovery support, in addition to the many studies that have been conducted on mutual aid groups, provides evidence for effectiveness of services in supporting recovery. Once the person is stabilized, that's mistaken for sustainable recovery. However, recovery is not durable until it is firmly nested in the community and within the physical and cultural environment of each person or family. So what that tells me is that recovery is a process. And not only do I need support while I'm in detox, not only do I need support while I'm in treatment, or maybe jail first, then maybe it was jail and then detox, or jail and then treatment. All of those need recovery support services. Having a criminal justice peer program could help with the transition from one place to another, and then from the treatment center to a recovery residence, from a recovery residence to stable housing. And in that process, you provide recovery support services. So just because physiologically we have stabilized and we've detoxed off the medications that we were using, whatever that drug is, that doesn't mean that we're recovered. And we just are maybe temporarily stabilized. And so then we need to bring in peer recovery support or other such recovery support services. Go ahead, Diane. Recovery support services are usually provided by volunteers, and they can be paid staff who are familiar with community support. A lot of treatment centers are utilizing peer recovery or recovery peer specialists in the state of Florida. They are certified through the Florida Certification Board. What other area? Oh, they use them in hospital emergency rooms when someone someone overdoses. They're used there as well. Peers are defined as persons with lived experiences. And let me tell you, there's 4 categories for peers. The first is adult, the second is family, the third is youth, and the fourth is veteran. And I always like to say that families are in recovery too. And as I began to recover and my children exhibited SUD, I had to start getting help for myself as well in a different way. And so I consider myself in recovery in a couple of different ways. And a lot of times recovery support services are free of charge or minimally charged. Go ahead, Diane. Recovery support services are generally non-clinical services that help individuals and families to recover from an SUD. They include linked and coordinated services with service providers. Sometimes you think, oh man, I have this problem. Where do I go for help in that area? Maybe you need some outside counseling for some trauma from the past, and you want the recovery support services to be able to link you to those providers. A full range of human services to facilitate recovery and wellness for improved quality of life. Workforce development. Again, we go back to a lot of times we don't have skill or we need help with a resume, writing, getting an email account up, an emergency department diversion program, criminal justice diversion program, and there are many other ways to provide recovery support services. Services that can be flexibly staged and may be provided prior to, during, and after the process. Remember, we talked about maybe jail being the first stop for someone, and then maybe into treatment. All of those stages come with different stressors, different challenges, and if you have recovery support services at each of those stages, that can help support the person in recovery. Go ahead, Diane. So research suggests that recovery services, support services, may enhance recovery initiation and long-term recovery maintenance. Because, again, you've got support through the continuum of care. Not only do you have the clinical part, whatever that looks like for the patient, the client, you also have peer support. There are many debates about whether the recovery outcomes differ from services provided by paid personnel versus volunteers. We're not going to have that debate here, but we are going to say that everybody brings something to the table. And that's important that sometimes we need to have paid personnel, and sometimes we need to have volunteers. Some people think that recovery support services should be provided by a treatment center, some kind of treatment organization. only by a criminal justice or a child welfare agency, by hospitals or other primary care facilities, public health, behavior managed care organizations, or behavioral managed care. Oh, I did that twice. Sorry about that. Either way, I think that recovery support services can come from all of those places and then some. It can come from a community organization. We're going to talk about that in a minute, a recovery community organization, which is a concept that is a national concept. There's national models, and they're being introduced into Florida as a way to continue support for folks. Go ahead, Diane. Research suggests also that recovery support services may be provided by community organizations, but there is a strong argument that recovery support services should be provided by an authentic recovery community organization. Recovery community organization maintains long-term personal and family recovery as its primary mission. They draw knowledge from the community of recovery as to mission, contribute to growth of local recovery space. They financially strengthen the infrastructure of the local RCO, and they provide peer support to workers providing recovery support services. Go ahead, Diane. The types of recovery support. We'll look over in the dark green. We're going to start there, and we're going to talk about employment services and job training and job searching. A lot of times getting into recovery, especially if you've just, I do have a question. I'll get to you in just a second. If you're just getting your life back together, maybe you've been in jail or prison for a period of time, you don't have an email address, or you need job training at all. A lot of recovery community organizations and recovery support will offer how to dress for an interview. They'll give you a voucher for a clothes closet so that you can go get a new outfit so that you could go on an interview. They might help you with writing a resume, preparing a resume, some interviewing skills. That might be, and even a computer sometimes, just to search for a job. Also, types of recovery support include case management with linkage to services. Sometimes, like I said earlier, we need to know where to find something. I have some trauma issues, let's say, and I need to meet with somebody who can help me work that out, and making those connections and being resources for the community services is important. Outreach. It's important that recovery support services help with outreach to the community through education, those kinds of things. Recovery support helps with relapse prevention. We touched on that earlier. Housing assistance and services. There are all kinds of housing. In our community here where I live, we have a recovery residence that is in stages. And the first stage is, I believe they're a level 3, and we're going to talk about that in a little while. And that is, they're closely monitored. They have curfews. They have some very specific rules that they have to follow. It's a woman's house. No man contact for 30 days. A few things like that. But then they have more independent apartments, and then from there they have completely independent apartments. So providing with the community types of housing assistance. Is there funding for housing in your community? Knowing about the funding for housing in the community is very important. And child care. Boy, I'll tell you, I have a friend of mine who just had twins about 2 years ago, and she tells me the child care bill that she and her husband share is just astronomical. And when you come into recovery, child care, in order to get the job or go to school or put whatever needs to be done, even searching for a job, you have to have your child in some type of child care organization. and knowing what kind of scholarships and programs that help with funding is important for recovery support. There was a question, what common conditions that prompt someone to get into detox or recovery? What are the common conditions that prompt someone? Oh, common conditions can be, I'm just tired of detoxing. I don't want to do this anymore. Sometimes it's the law takes care of you. A Marchman Act, a family might file a Marchman Act, and that would prompt someone to get into recovery. The loss of children. Sometimes the state or another organization comes in and takes a child away, and either temporarily or permanently, and that can prompt someone to get into the recovery process, either through detox or another part of the recovery journey. So sometimes it's just saying, you know what, I don't want to do this anymore. Mine was going to jail in another state and my children being taken away from me. That's what prompted me to get back into a process of recovery. So they can look a lot of different ways. And the fact is that however you get there, that's where the importance of recovery support is important. You can change the slide, Diane. Other type of recovery support includes transportation to and from the recovery support activities, whether it's through a bus voucher. It could be that maybe a recovery support service has a bus, a van that they'll come pick you up, or you can get a ride from a peer. Maybe you're connected with a recovery peer specialist, and they say, you know what, I will take you to your probation, your first couple probation meetings, or I'll take you to meet your case manager for with Department of Children and Family, or I'll take you to court, whatever it is. But having that transportation is important, and knowing what kind of recovery support is available in the community is also as important. Family and marriage and education. I talked about earlier how I had to relearn how to put a family together, and I had to ask for help. I was not married, and so I didn't have to worry so much about marriage, holding a marriage together, but I did have to worry about how I was going to hold my family together and help them, and knowing where those resources were important. Peer services, mentoring or coaching in the community, peer-to-peer, whatever that looks like for a community. Sometimes it's, like we talked about earlier, it's in a treatment center. Sometimes it's through a peer recovery support service like a recovery community organization. Self-help groups are important to know where they are because there's a lot of them and they're different for everybody. Life skills training. Something as simple in a recovery residence is you can't leave the house until you make your bed. And that is a learned skill again. Doing the dishes and not leaving the dishes in the sink. Going grocery shopping, learning how to eat healthy, how to get a checking account, how to pay your bills. Those are life skills that are important. Parent education and child development services, again, having those resources and those supports in the community is important. Diane, did you want to take a break or do you want me to continue?
Let's go ahead and take a 5-minute break at this time. And I'm going to see, Jenny, if we can get you back into controls of your PowerPoint.
Okay.
In the meantime.
Beautiful.
Okay. Everyone,
Okay.
5-minute break. We'll come back at 3:04. Thank you. Hello, everyone. Welcome back to today's webinar. Ginny, LaRue, if you're ready, I'll turn the presentation back over to you.
So I went ahead and moved it to the slide that we're going to talk about next. Although I did miss a question, and so let me go ahead and address that right now. Marla Russell talked about, have you lost funding for beds, and how many beds do you have? And I'm assuming you're talking about the organization that I work for. It's a 13-bed facility, plus we have a house manager's apartment. It's a separate apartment from the house. It's over the garage. And our funding doesn't come from outside sources. It's self-supported through the folks who live there. So we don't get outside funding. I hope that answers your question. And I think I got everybody else. So we're going to continue on. And as we were talking about recovery support services, one of the things that I have discussed, and this is what I'm doing for a living also, but I wanted to talk about that as being an option, are recovery community organizations. It's a national model that is working throughout the United States. RCOs are independent, nonprofit organizations. They are governed by persons in recovery from the local recovery communities. Remember, families are in recovery. They do not provide clinical services. Now, that does not mean that they don't have a clinician come in and maybe do chiropractic adjustments twice a month. Or they might have somebody come in and do HIV or Hep C testing once a month or twice a month. There are a lot of things that you might have a clinician to come in and do, but the services are not clinical. They offer a variety of peer-based services and programs, public education, public advocacy, or policy advocacy, and recovery support services. Remember, we talked about some of those peer-to-peer, helping people in the workforce, doing an ER diversion program. There's one place in Rome, Georgia, that they have a workstation set up, and they have partnered with the local college, and they have their career services folks come in and train twice a month on how to write a resume, job skills, things like that. Another one they partnered with, they got a grant for a greenhouse, and they worked with the criminal justice system, Department of Corrections, and they partnered with a local elementary school. And what they did was they had the local elementary school plant seeds, vegetable seeds, and that was their science project for the year. And then they brought those cultivated seeds to the Recovery Community Organization, and then from there, the people that were on probation and needed community service hours would cultivate those plants in the greenhouse, and then they had the basement in this. They actually have basements in Georgia, and then they cultivated those plants and those vegetables, and then what they would do is they would take them to the local farmers market, and they would sell them, and there would be sustainability back into the organization. And you partnered with several organizations in the community to show that recovery is possible. Another is a broad mission of an RCO is to mobilize resources within and outside of the recovery community to increase the prevalence and quality of life and quality of long-term recovery from SUD for both individuals and families. Oh, yay, it's working. Okay, so this is some of the work that we're doing in RCO development in the state of Florida. So you see, we're in the infant stages, but it is beginning to come about. In the states, there are already currently 3 recovery community organizations. We have one in Margate, one in Kissimmee, and actually they just opened another one up over in the Melbourne area. and then another one in St. Petersburg. And then there are 2 other ones in West Palm Beach, and then Floridians for Recovery is turning into the statewide RCO. And then you'll see the RCOs that are currently under development, and that is where we're going into communities and finding recovery champions and working at moving the community so that it's grassroots. It's not just Ginny, LaRue, or FATA going into the community. It's the community saying, okay, we want to support this, whatever that looks like. Okay, so housing, because that's what we're here for. We're here to talk about housing, recovery residences. So in Florida, there is the Florida Association of Recovery Residences, and they're known as FAR. And then nationally, there's the National Alliance for Recovery Residents, which is known as NAR. A lot of the standards that are Florida standards are borrowed from NAR. FAR evaluates and monitors standards-based recovery support services throughout Florida, provides recovery-oriented housing for persons seeking an abstinence-based, peer-supportive environment. Now, nationally, for NAR, they create national standards for recovery residents. They do a lot of advocacy. They do a lot of training and education, and they provide technical assistance. Let's see. I'm trying to look. There's a couple of questions. There was a couple of questions about attending this webinar. In the beginning, there were some directions about that and CEUs. Okay, we're going to continue. Oh, there we go. Okay, so housing. Recovery residents, sober living houses, they're also called recovery homes, Oxford houses, are sober, safe, and healthy living environments promoting recovery from an SUD. They offer peer-to-peer recovery support and some professional services used to promote abstinence-based recovery. Recovery residences are in the continuum of recovery. There are 4 levels, level 1, 2, 3, and 4. So a level 1 are similar to an Oxford house. I'm sure that many of you have heard about an Oxford house. The resident self-identifies as in recovery and ready for peer community accountability, community meeting the recovery residents. There is no on-site paid staff. It is democratically run, and it provides on-site peer support and on-site mutual support groups outside clinical services. So there's no clinical services that would come into a level 1 recovery residence. A level 2 sober living home would be an example. The resident is stable in recovery, wishes for more structure, and seeks peer accountability and supportive living environment. Has an on-site house manager, often compensated. Residents participate in governance with the staff. Hosts a community house meeting, outside mutual support, and outside clinical services. So the recovery house that I'm a part of, where we would be considered a level 2. We do have an on-site manager. She is compensated with housing, and we allow for residents to participate in the governance of the house. And we don't have inside clinical services of any kind. A level 3, residents have moderate structure of daily schedule and life skills support. They have a paid house manager and maybe other staff, and possibly certified recovery peer support service providers. Resident participation varies. Senior residents participate in management decisions. They may be licensed, and they may use peer recovery support. Community house meetings, buddy systems linked to mutual support and clinical services in the community, and then peer support services. A level 4 is residents require clinical oversight or monitoring, and stays in that setting are briefer than other levels. They usually have paid, licensed, or credentialed staff and administrative support. The resident participation varies. Organization authority is hierarchy, and there is clinical supervision. On-site clinical services, on-site mutual support group meetings, life skills training, peer recovery support services. Oh. Any questions? I'm kind of trying to take a look at the box for questions, and I don't really see any. That anybody have any questions? Now's the time. Okay, we're going to continue. So, objective 3. Consider the stigma present in some facets of the recovery community impacting parents with opioid use disorder receiving medication-assisted treatment. Stigma. We talked about this in the earlier parts of this presentation, but I'm really going to talk a little more deeply about stigma. We don't realize what we're doing when we stigmatize people. We've come a long way in a lot of areas of our cultural population in how we stigmatize folks, but we are not there yet with persons in recovery. We still have a lot of work to do. So stigma is defined as a mark of disgrace associated with a particular circumstance, quality, or a person. So there are a lot of groups in the community that you all know about that have really gone out and said, we are here, we have a voice, we vote. Women's rights, they changed the stigma, and that's still going on. Stigma of addiction is a mark of disgrace, or it's not a good associated with the disorder. Personal shame and public stigma create obstacles to an individual addressing an SUD. A lot of times, employers are not recovery-friendly employers because of criminal background checks, because you identify as a person in recovery. Actually, I find that most people that are really engaged in a recovery program are really, really, really good employees. They show up on time. They're not calling in sick all the time. They really end up being good employees. So stigma of SUD may be a barrier to effective SUD prevention, treatment, and recovery efforts for the individual, family, community, and society. Stigma may prevent people from getting the help that they need. I shared earlier about a friend of mine who, her son is just almost a year old, and when she had her baby, it was her second child. Her first child was born substance dependent. Her second child, because she'd been in recovery for a long time, was not. Yet she still felt that stigma that went on from the clinical staff that worked with her in the hospital. And that takes time and education on the community's part. So stigma about medication-assisted treatment. This is the kind of things that we hear from people who are on MAT. You're still using an opioid. You're not clean. You're using it as a crutch. The person is still addicted. They're not in recovery. They're treading water, not going anywhere, not moving forward. It's just social control, liquid handcuffs, and that's just a few things that I have heard said or have read about being said. Stigma of MAT is among the most evidence-based recovery management strategy for individuals with OUD. It is evidence-based that this is working in the lives of people, and there's some power in that. So how do we reduce the stigma of MAT? Well, first thing is we educate. I educate my colleagues as a recovery house residence owner about how I operate a recovery residence with MAT residents. I talk about the nature of addiction. Most people achieve remission, but it takes time. MAT is the most effective approach to facilitate long-term remission of OUD. We have to celebrate every pathway that saves lives and facilitates long-term change. When I work throughout the state, I talk often, all the time, constantly about multiple pathways. My way is not the only way. The way that I entered the drive into my recovery journey is my way, but I have to embrace the other ways to recover, because my way is not the only way. So multiple pathways of recovery, that needs to be celebrated. There needs to be a recovery movement in our communities that embraces all of that. There's a question here when we were talking. I'm going to back up just a little bit. Kathy Cook asked, do most people start in a level 4 facility and progress down when it comes to recovery residences? Some may. It depends upon your point of entry. Sometimes treatment centers have a recovery residence and that would be more like a level 4. And then they may stay there. Remember, level 4 is very short-lived. So then they may go to a level 1 or a level 2 or a level 3 from there. So it not necessarily. Some people go through detox, and detox is all they need. They are now abstinence or are managed on an MAT, and then maybe they go to a level 2 that accepts MAT. So it doesn't necessarily mean that everybody starts at a level 4. It just depends upon your on-ramp into the recovery process, and everybody's on-ramp looks differently. Let's see. I wish I could see the rest of the question. Shelley said, I work with pregnant women in a residential treatment, but recovery houses, having difficulty seeing the rest of the question. If anybody wants to try and chime in who's able to see it.
Jenny says,
yeah.
I work with pregnant women in residential, but recovery housing on discharge, impossible for moms with infant children. Is this area state working to improve options?
Got it. Okay, we're going to talk about that when we start addressing the fourth objective in this. So hopefully I can answer that question through that process, Shelley. Good question, though. All right. Personal stories. People respond to stories. There was a comment in here made about, thanks for sharing, thanks for getting vulnerable, thanks for telling your story. You guys responded to my story. You guys said, wow, okay, that takes a level of vulnerability. That takes some honesty to do that. You know what? If I start listening to more stories of success, more stories of recovery, that will change how we feel. We just did a recovery symposium in Volusia County this past weekend to start the RCO process here. And we had a young lady who was on Vivitrol, and she was on the panel for persons in recovery. And she moved the room with what she shared. She was pregnant. She hadn't been able to stop using for a long time. She stopped using. She's put her life back together. She has recovery support services. She goes to a 12-step fellowship. She is now pregnant. She is engaged. She is going to work every day. And she shared her story, and it was powerful. It moved the room. There was another woman on that panel who talked about her Hispanic heritage, and she talked about what recovery had done for her. She talked about addressing mental health. She didn't realize that she had mental health issues, and it needed to be addressed. People listen to stories. And so the more we start sharing success stories and stories about people who have experiences with MAT, we need them to tell their story to community organizations, to all kinds of ways they need to get their story out, because people will begin to see that, man, change is happening. Change our language. Woo. This is important. Terminology that is consistent with the nature of SUD, OUD, and policies about recovery must be addressed. Move away from terms like junkie, heroin addict, opioid use disorder. Shift away from MAT to opioid use treatment or opioid use disorder treatment. So our language stigmatizes, and how we talk about our very clients, our very people, my peers in the house, it's important that I choose my language about them and with them carefully. I found this and I thought this was really cool. Stigma and language. So this is a what to say and what not to say. So on the left side, you'll say this, a person with an SUD, but don't say a druggie, an alcoholic, an addict, a junkie. Person living in recovery. When I introduce myself publicly, I am a person or a woman in long-term recovery. I'm not an ex-addict. I'm not an ex-junkie. I'm not any of those things. I'm a person living in recovery instead of saying ex-addict. Person living with an addiction, battling or suffering an addiction. See, person in recovery, we stop the battle. We're not suffering anymore. We may have some challenges, but that comes with life. Person arrested for a drug violation, drug offender, chooses not to at this point. How many of you all, just think about it, how many have said, that person is non-compliant, they're not ready, they're not willing? You know, again, recovery is self-directed, and we've got to help our people, whatever they look like, in whatever form or fashion you're working with folks, make their own choices. Just because they're non-compliant now, in technical terms, doesn't mean that they won't be later on. So we have to let them know that for right now, you're choosing not to do that at this point. Maybe that will change. Medication is a treatment tool. Medication is a crutch. Preventable, treatable health condition. I love that. Substance use disorder, opioid use disorder is preventable, it is treatable, and it is a health condition instead of relapsing disorder. Some more stigma that all of us have used. I've used it. I'm on a committee in my community, a substance use task force, and we're redoing our mission in that task force. And as I have a new set of eyes, I started to look at that mission and I went, oh my gosh, there's a lot of stigmatizing words in there. We need to change that. And so I got on that committee to redo the mission. So say maintaining recovery instead of staying clean and sober. Positive drug screen instead of dirty drug screen. Ally for recovery instead of enabler. Remember, families are in recovery too, friends too. Ambivalence instead of denial. Had a setback instead of relapsed. Elevator gets off at every floor, hits bottom. So those are just a few examples. I'm sure there are a lot more out there, but I thought that was interesting. So recovery residences. Some of the problems with recovery residences is that you'll find a lot of, like on NAR and FAR websites. I did some searching, and I actually emailed the executive director of FAR and said, hey, you got some stigmatizing language on there, and he fixed it. And the more I see, the more I'm going to let him know. We need to encourage, we need to stay away from abstinent-based language, and we need to encourage multiple pathways. And we need to educate providers who are generally persons in long-term recovery about the stigma, MAT, and multiple pathways of recovery. You know, and that's going to take a little bit of time. So mutual support groups, one such mutual support group, or depending upon which one you're talking about, there are a lot of them, Narcotics Anonymous, Alcoholics Anonymous, Al-Anon, Nar-Anon, Heroin Anonymous, Methamphetamine Anonymous. There are a lot of anonymous programs out there. Their philosophy is usually abstinence-based. Several 12-step recovery groups do have published material about MAT. One of them addresses this issue by saying, they have a pamphlet, and they address this issue by saying that it is an abstinence-based program, but the only desire for membership is the only requirement for membership is a desire to stop using. I'm sorry, that is a typo. Smart recovery, this pathway is abstinence-based but not based on 12 steps. Smart recovery supports the scientifically informed use of psychological treatment and legally prescribed psychiatric and addiction medication. Celebrate recovery does not take a stance on MAT. I could not find anything about that. Celebrate recovery is 12-step based, but the higher power concept is Jesus Christ. It's biblical, and these groups, they deal with all types of addictions like drug addictions, gambling, sex, emotions, all that kind of stuff. So it encompasses for them everything. Natural recovery. You don't have to go to a 12-step to be in recovery. Remember, there are multiple pathways. It is the most common recovery pathway, but the prevalence of this style declines as problem, duration, and severity increases. Natural recovery is a more viable pathway for people with shorter and less severe SUD problems and for those with higher incomes and more stable social and occupation support. Recovery support services, common and effective means where individuals find sustained long-term recovery. Recovery coaches are a pathway to recovery. Some people don't use other things, but they might use a recovery coach as a form of support. It's different than a 12-step sponsor. Medication-assisted recovery is the use of medication in combination with counseling and behavioral therapies for treatment of SUD with an emphasis on robust recovery support services. Family recovery. Addiction has the same effects on family as it does on the individual. That is the truth. Anger, distrust, resentment, codependency, intergenerational violence are examples of consequences from addiction. Families must heal, and that means families find recovery or together with the individual. I shared earlier that my middle son is now in treatment. And, I still have some resentments from his use because it caused a lot of turmoil in our family. He just had a baby before he went into treatment. And as a family member now, I have to deal with the distrust and the resentment that came from that. I have things on my wall in my office about detachment to help me remind myself that I am in recovery from this in this part of my life as well. Are there any questions? I don't think there are any new questions.
Jenny?
Yeah.
There is, what are your thoughts on individuals that enter MAT and continue to use low-risk substances like THC and cocaine? They have a higher chances to relapse than those that remain absent from low-risk substances?
That's a really good question. And, I'm going to have to go back to what changed my mind about medication-assisted treatment over a year ago. And my personal opinion doesn't matter, but the philosophy behind it does. When Justin from Rebel Recovery was on that stage and shared, who am I to say that the guy living at home in his apartment, still smoking pot, but paying his bills, not living behind a dumpster anymore, why can't we see him as being in recovery? Because he's not opioid use dependent anymore. He's smoking pot. Now, am I advocating for the use of cocaine or marijuana? Personally, I don't advocate for that. But if the person is still functioning and still doing what they're supposed to do, why can't we begin to change our thinking to say, maybe that's the on-ramp for them. Let's find their on-ramp for recovery. And if that is their on-ramp, where they have to do MAT, and I believe, Diane, you said cocaine and THC or marijuana, that might be the on-ramp that they need to stop doing the cocaine or the marijuana. So my opinion about it is that there are multiple pathways of recovery. My way isn't the only way. Do I personally advocate for that? I don't personally advocate because that's not my story. I don't have that experience. I can't share from a place of that. But I can tell you that I've met people who have. And some were successful, and some are still on their recovery journey, whatever that looks like. So I don't know if that answered the question, but I'm hoping it did. Did I miss another question, Diane?
I think you're good.
Okay. Okay, last objective, and I'm hoping that'll answer the question about pregnant women and housing for women. Describe the benefits of a need for recovery residence for parents with OUD. So the benefits of recovery residence is accountability and responsibility, structured living, peer-to-peer support, and help with transitions, healthy new environment. Obviously, you want to promote recovery from SUD, may provide clinical services, help with transitions, decrease inpatient and post-treatment relapse, benefit contingent on adequate lengths of stay. Usually for a level 1, it's 6 months or more. I've seen women stay in my recovery house who had a lot of legal issues and a lot of issues with her children. She stayed almost 18 months, so they're going to look different for everybody. Again, multiple pathways. The benefits of recovery residence are cost effectiveness, varies depending upon the structure and the ownership of the recovery residence, and scholarships availability. Some communities, there are organizations that do help with finances for recovery residences, at least to get in initially. Recovery residents do not negatively affect neighborhoods and generally provide benefits to the community. I consider my community, I'm a good neighbor in my community. We pick up our trash. If trash is thrown around the front yard, we mow our lawn. We make sure the house is painted. We just replaced the windows in the house not too long ago, back in November. We keep up with the look of our house. We decorate during the holidays. We are involved in our house. It is a home for the people who live there, and that is their community. Recovery residents do not discriminate toward MAT individuals in the screening criteria, as this does violate, by the way, Title III of the Americans with Disabilities Act by refusing to accept a patient because they're being treated with an OUD. There is a case in, I forget the state now, where a ALF was sued for not taking a patient. I think it was a nursing home where they would not take a patient who was on an MAT, and the person won. We are doing a disservice, and I know a lot of times recovery residents will say, oh, well, we don't have a bed, because they just don't want to deal with, they don't want to say we don't take MAT, but they'll say I don't have a bed, or you don't meet the admission criteria. But to actually turn somebody down because they're on a medication-assisted treatment program is against the law. Certified recovery residences, Florida, and remember those are FAR accredited residences. There are 392 FAR accredited recovery residents. But this figure does not account for non-accredited recovery residences. At this point, and at the time of this writing, there are 3 level 1s, 241 level 2s, 64 level 3s, and 84 level 4s. And you could go on the FAR website and find out where they were located and what they go through a list of what they do, etc. And somebody just asked, Marley asked, regarding the not discriminate toward Matt, recovery residents may have exclusionary medications, though. Yes, they may, and that's absolutely up to the recovery resident's owner. But again, you have to be careful about discrimination in that process. So depending upon the medication, you weren't specific, Marley, but you can be found as discriminatory. Certified recovery residents in Florida. So if you went on the FAR website, you could filter by program, number of residences for that program, like men, women, locations. Some are LGBT, some are co-ed, some are women with children. Now, I'm going to go back to that question that was asked earlier. There aren't a lot of recovery residences throughout the state of Florida that accept women and children, and that is a problem. A lot of times they'll accept the woman or the man without the child. And so communities need to start advocating and helping with the process of finding housing that will help women with children, men with children, so that they can begin to reunite their house. There are some, and you can find some of the certified ones throughout Florida on the FAR website. And again, they'll give you levels, what their rental fees are, their membership fees are, and then more information about the recovery residents, and sometimes it'll take it to their website. There are additional costs, the additional costs associated with recovery residents. Roughly $3,000 are returned nearly tenfold in the form of reduced criminal activity, incarceration, and substance use, as well as increases in earning from employment. We're paying taxes again. We have stable housing now. We're accountable for staying engaged in recovery, whatever that looks like. We're getting recovery support services. That's helping the community. I always used to say, now this is not necessarily the case today, but early in recovery, my father's an Episcopal priest, and he'd say, come to church, and I'd say to him, Dad, the community is better off for me to be in a meeting than for me to be in church. And that's not the case today, but back then it was, and I became a better employee. I told you I became a better dog owner by being in recovery. I'm a better human being by being in recovery and not doing the things that I did in order to continue to use. Other studies show that residents of recovery residents are more likely to report abstaining from substance use at a much higher rate. Residents at 6 months were 16 times more likely to report being abstinent or engaged in recovery. Residents with 12 months were 15 times more likely to report being abstinent or engaged in recovery. And residents with 18 months were 6 times more likely to report abstinence or being engaged in recovery. Certification with the Florida Association of Recovery Residents is voluntary, but since June 1st, 2016, Florida now prohibits licensed substance abuse service providers from referring patients to a recovery residence unless the recovery residence holds a valid certificate of compliance and is actively managed by a certified recovery residence administrator or is owned and operated by a licensed service provider or a licensed service provider's wholly owned subsidiary. So that means that as a clinician working in a licensed substance abuse service, as a licensed substance abuse provider, you cannot, because of this new law, refer directly to a recovery residence that is not FAR certified. Now, that does not mean that your patient client cannot say, well, I want to go to XYZ recovery residence. They make the phone call, they find out the information, the client that is, and they can refer themselves directly there. You can't stop them from doing that, but you cannot make a direct referral in the state of Florida. Let's see. I'm going to kind of finish up. There was NPR did a little story about recovery houses won't let residences use medication to quit opioids. And if you get a chance, when you get a copy of this PowerPoint, take yourself to that link. It's an interesting story, and it takes on a new persona that, recovery residences really do need to take a look at opening up their doors to medication-assisted treatment. And as communities, we need to start looking at options for parents with their children who are still united with their children to recover or start their journey of recovery in a recovery residence for families, whether that's husband and wife and children, or mother and children, child, or father and children, child, because sometimes it's the father too. So I am, I believe, done with my presentation. I know that there's some additional training. So I'm going to really kind of pause for a minute and see if there's any other input from some of our other professionals that are on this call, and also to see if there's any other questions. Okay, Diane?
Can you expand a little bit more on the different levels of the housing and what's going to, with the levels of housing, how that, or maybe John?
Well, I did talk about the housing as 4 levels. Now, again, these are based on national standards by the National Alliance of Recovery Residents and also FAR, Florida Association of Recovery Residents. They have identified 4 levels. And somebody asked a question: is it required to go into the 4th level? Is that the only on-ramp? And I talked about the different on-ramps that there are for the different levels. So level 1 being really they're self-supporting. It's just a safe house that requires everyone to be engaged in recovery. And then level 2 is, and it's democratic in nature in level 1. They vote, they decide, okay, we're going to collectively do this. They may have communal meals, they may, they just support one another. Whereas a level 2, those things still apply, but there's a little different hierarchy. You might have a house manager who oversees the organization. And then a level 3, they might have some programs included, life skills, things like that. Outside clinical help come in from time to time. And then a level 4, like I said, are usually associated with some type of recovery treatment center, mental health center, something like that. And they're really, those guidelines are much more stringent on, they're not able to just leave as they want. They usually have clinicians involved, full-time paid staff involved in that process. Did that kind of answer your question, Diane?
It does. The other question that just populated is, could you mention that the new legislation for next year will remove the exemption for recovery residents that are under wholly owned subsidiaries?
I don't know the answer to that question. That is something that we're going to have to get back to you on. I can find out, and we can include that in some of the responses that we talked about. You're talking about legislation for that's being voted on or that goes into effect next year? I don't know who wrote that, but.
That was the question on one of the questions that I received on my end.
Oh, okay. I didn't see that question. We will make sure that we note that question, and whoever wrote it, we'll make sure that we get back to you directly, or we can do that collectively to everyone.
Okay. Is there any other questions that anybody else has? We have a few more minutes before we conclude. So anybody have questions? Steve, if you can, you're in listen-only mode. Steve Farnsworth, if you can post your question into the Q&A or in the chat, that would be great. Thank you.
Oh, yes, awesome. That's right. Steve Farnsworth is the executive director of FAR, and I'm glad to hear that he's on this call, so he may be able to answer that question directly.
John, do you have anything you would like to share? Steve reported he said it wasn't a question. It was a statement that the new proposed legislation will remove that exemption. Mary Muldowney, sorry if I'm with your name, why does the percentage of recovery drop from those who are 18 months in recovery? Why does the percentage of recovery drop from those who are 18 months in recovery, is the question.
Was that for John?
This is John. Ginny, I think that's referring to that slide you had up about the 6-month rates and the 12-month rates
right.
and the 18-month
right.
rates. So I think possibly the best way to answer that, if you have it, is just the reference to the study or the stats on that. So I don't particularly know that answer offhand for Florida.
Well, I can tell you that the reason I pulled that in is because without recovery supports and with recovery supports, those figures change. And the idea is that not everybody stays abstinent for 18 months. So those numbers are inherently going to drop because of lack maybe of recovery support services in a community. So I believe that by increasing recovery support services, again, through an RCO, through peer support, et cetera, some of the things that we talked about, that would increase that number eventually. But I think the numbers go down because unfortunately, not everybody stays in recovery, or they drop off, but they're still in recovery and we're not necessarily reporting them. So just because we don't see them in recovery doesn't mean that they're not in recovery. I hope that answers that question. Let's see, Mary asked that question.
Okay, thank you, Jenny. This is, thank you so much for coming. Thank you, John, for being on, and for coming and being here. I am now going to go ahead and we're going to conclude today's webinar. Your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health licensed prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through your WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Evaluation will close at midnight on Monday, February 4th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education and JBS International. Have a great rest of your day and please hold for the evaluation.